Tonight we are doing things around clinical governance. So it's one of those topics that people kind of don't necessarily shy away from, but also they don't necessarily feel that enthusiastic about probably. A lot of the time it's one of those slightly drier topics. It's not the exciting ultrasound images. It's not looking at lovely pictures and videos of pathology. But it is a really, really important area, and it's something that we wanted to dedicate a whole session to, because it's something that on the courses that we teach and that we run, we find people actually really engage with this topic very well and actually find it very, very beneficial. It often prompts a lot of thought for people when they go back into their clinics, whether that's in private practice, in the NHS in the UK, whether it's point of care, whether it's radiology. It gets people thinking about what they do in their practice. Okay, so it's obviously a massive, massive topic. It's got lots and lots of different areas to it, but we've tried to choose tonight a few different areas. It's the usual crew, so myself, Stu, Dave, and Rob, and we're also delighted to have Doug back with us after huge public pressure to bring him back in tonight on a performance fee tonight as well for you, Doug, because of the crowd baying for your presence on the webinar. So thanks again for Doug for coming back and sharing your expertise again. So to start off with, one of the key things is around quality assurance, and we're going to look at some of the aspects of that. You can break that down to three key things really: assuring competence, assuring service provision, but also assuring safety of equipment. Now, we're not going to go into training and competence particularly tonight, but we're going to look around things such as safety of equipment, and then we're going to look around elements of service provision. So things such as reporting the challenges of image storage, some of the aspects and the basic key aspects around infection control and how you should tackle those scenarios in your practice with your system. And then touch on some of the other elements around audit, policies, and some of those other areas that are really, really important. I think particularly, all of it's important for patient safety, but particularly important for patient safety around policies and protocols and governance, and those kind of things. So to start off with, we're gonna chat about probes. I think ultrasound probes and what sort of damage can occur to ultrasound probes, and then we're gonna link into Doug's going to do a little feature around how you can monitor your probes and everything else. In terms of damaging probes, touch wood, hopefully I've never damaged a probe as far as I know. Has anybody had a situation where they've damaged a probe?
How would you know, Stu?
Well, might as well put the bold questions out first.
Yeah, when someone picks up a broken probe from the scanner, then you don't really know who did it, do you?
Yeah, I think one of the key things about tonight is that a lot of the time, I think we can easily sort of get ourselves into lull into the full sense of security, if you like, of assuming that the image we see on the screen is accurate and is what it should be. And in less experienced eyes, sometimes you won't pick up on changes in that image quality because of the health of the probe or the system or whatever. So what I'm going to do to start with, just to sort of fire up the conversation a little bit and tee Doug up to sort of take over a bit, is just share some images around probes and the sorts of damage that can occur to ultrasound probes and things. This is just really for geeky interest, really. So these are sort of the sort of things that can go wrong with ultrasound probes. We'll just share that screen so it looks a bit better. Hopefully everybody can see that. So these are the sorts of things you're looking for. So you can certainly be looking for cracks in cabling, so the cabling where it sits adjacent to the actual probe itself. We'll chat a little bit more in a minute and get Doug's knowledge going around the wires and the ultrasound probes and cables themselves. Certainly cracks around probes, if you drop a probe, those kind of things, these kinds of issues certainly can occur. And this is what an ultrasound probe theoretically looks like inside. And Doug, maybe if I draw on you to sort of comment about this at this point.
Yeah. I mean, this is one of the things, the cable outside it's smooth, it's white, looks rather boring, but inside there's an awful lot. And you've got to remember that the echo information in the probe that's received by the transducer is translated into very, very small voltages, and voltage changes that are happening in the megahertz range. And electricity at very high frequency has some interesting characteristics. It leaks. It moves out of a cable. It'll find a way into other cables nearby. So each of those tiny wires that you saw in that one cable is a coaxial design, so that it keeps the electricity in it. And if it gets damaged, then that electricity will leak out. And one of the enemies of those tiny voltages is what's known as EMC, which is electromagnetic interference. And that's interference and crosstalk from the cable, each cable itself, to its neighboring cables, but it's also anything electromagnetic outside. And if you can go back to the slide that you showed after that, Stu. With the showing the broken apart cable, that's it. That one.
Yeah.
You can see on that there's actually some. Hopefully, you guys can all hear me. I just had an unstable connection come up. But there's actually shielding surrounding that cabling as well. Now, when you run over a cable with your ultrasound scanner, which happens not infrequently, what you're doing is you are compressing all those little cables together. You're getting to move around, and they're small. They're not that strong, and they can get damaged. And that damage will build up progressively. And eventually, you'll start to get what are known as, you can sometimes see it, if you take the probe cable and you do that with it, or when you're scanning and the cable moves, you may see what are sometimes called shooting stars in the image, a kind of comet effect. And that is a clear sign that you've got a damaged cable.
And the classic ways for those, as you say, are, running over the cable. They're quite long, aren't they? Unless you have the little hook on the system where you just hook it up, keep it out of the way. It's a classic area where issues can happen like that. And how easy is it to replace probes, Doug? Is it changing a plug on a lamp?
Far from it. Each of the in the cable has to be connected to the transducer element in the array, and that's it's not an automatic task. It's highly manual, and it's very often an extremely skilled task to do that properly.
That sounds expensive, Doug, the way you're saying that.
Oh, it is. And high frequency probes in particular have quite high rates of failure in manufacture. And that's one of the reasons why high frequency probes tend to be more expensive than lower frequency probes.
And presumably the probe itself, the actual probe head, I don't know if you've got one there, you can just sort of pop on the screen, Doug, yeah. But the probe itself and the cable all come as a unit, don't they?
Yeah, single unit.
When you purchase that or whatever, and the end part as well.
Yeah, and the cable connector, you've got to remember that inside the connector on that goes into the scanner, there's got to be, again, an equivalent number of connections, each of which must function perfectly to translate and transfer those voltages back into the machine so that it can start to process them. Sometimes manufacturers will put a little bit of processing, a little bit of amplification into the system before the electricity leaves the probe. Because if you can do that, then that boost, that bit of amplification helps to reduce the amount of the effect of crosstalk and poor connections. But poor connections are a really, really troublesome factor in ultrasound, because these voltages are absolutely tiny.
Yeah, yeah. I think I've got a couple more images. So yeah, we talked about sort of cables. We talked about the sorts of things that can happen to your systems, and this is why it's so important to look after your kit and stuff. This is a nice image that we often use on our cadaveric injection course and our injection programs. Just shows you, you know, a needle issue here, a sort of a puncture from a needle tip, coming too close to probe. You know, the classic thing with these kind of issues is that somebody's looking at the screen and the needle is heading in that trajectory as opposed to that trajectory, and it's a reasonably common thing that can happen. And you know, you can see the corresponding ultrasound image here in the bottom that shows you that dropout. Now, you know, that looks pretty obvious.
Interestingly enough, that's not dropout. That's just the acoustic lens has been affected, so you're getting the appearance there, because you're not getting the echo reverberation inside the acoustic lens at that point.
That's me trying to chuck out some technical lingo there without fully understanding it, probably.
Okay, so the dropout, because this actually happened on one of our probes.
Dropouts the crystals.
One of your courses. I dread to say that, but it is actually what happened. When we tested the probe, there wasn't any dropout at that point, but the acoustic lens has been damaged, and actually it was what you were also getting was because the voltage goes onto the transducer, there was a loss of actually the electricity could leak out at that point. So you can sometimes, I've had this in the past where a patient being scanned has said, "Oh, that tingles," and that's a sign that the probe is no longer electrically safe.
Yeah,
Wow.
yeah.
Because the voltage is this is actually in transmission. The voltage is quite large in transmission, and that voltage is leaking out from the probe through the gel onto the patient's skin.
Wow. And this area here as well is obvious in that image there, isn't it, as well? But when you're actually doing a live scan, grayscale image, that can sometimes be less obvious to less experienced eyes. And so this is why it's so important to check these kind of things. You also can obviously get wear, can't you, of this face here, and other sorts of, you know, again, we'll go on to cleaning products later, but that's probably a relevant point for cleaning products later around.
Doug,
you can get abrasive effects and you can get chemical effects on the acoustic lens.
Yeah, and that's
so
why.
Doug, sorry, in this case, could you replace that lens then?
No.
So what do you do with it?
On.
You can't do anything with it. It's just...
The right.
Some people do repair, you know, acoustic lenses, damaged acoustic lenses, etc. There are companies that do that. How effective they are, I don't know. How well, you know, they may be able to make the probe electrically safe, but has it returned the performance of that probe back to the manufacturer's specification? And that's the nub of this. There are, you know, if you think about the break in the cable, the rip in the cable cover, you know, again, if you run over the cable, what you may get is a small tear in the cable outer covering. Now that again is no longer, you know, I would say that damage is something that needs to be repaired. The manufacturer would most likely want to say, well, we wouldn't repair it, but you might want to put some shrink wrap around it, for example, to repair it. Now that's a non-authorized repair. So if, for example, you had an electrical, you know, someone got an electric shock off it, or an electric shock or something like that, that might be inspected and then tracked back. So when a repairer has repaired the probe, They may have repaired the outside of it, but they also may not have seen what other damage is inside it. So you do have to be careful of that, I think. And I would always suggest that an authorised repairer or an authorised body was used to assess that probe properly. That's usually the original equipment manufacturer.
And this is where this just links in, doesn't it, to the whole concept of regular and routine sort of phantom device testing as well. You know, you tend to see that pretty rigorously within radiology sort of settings in terms of quality assurance and phantom testing on regular intervals. And I think it's more difficult sometimes for people in point of care environments to get that sort of guidance and advice around that, perhaps. But Doug, you're going to show just a little way potentially now, just the way that people can just sort of check in a very, very simple way. It's not by any means totally exhaustive of what can be done around quality assurance and probe testing and everything else.
I'm going to change the camera, my camera, so bear with me a moment.
Let's stop that share and just...
you can still hear me, but I'm just changing cameras on my machine.
So while you're doing that, Steve Wells is sending a question saying, are phantom devices expensive? I don't know if, Dave, if you've explored phantoms and ways to test systems and things.
That's me.
Hey,
Right,
yeah.
can you share the screen as well, Stu, while you're talking? Or
Yeah. Carry on, Dave. Carry on, Doug. Yeah, do that while Dave's answering that question.
Yeah, so my experience of phantoms has been that that they are they are certainly pretty expensive to buy if you're buying them in in private practice. Obviously, if you're going to sort of purchase a phantom so that you can do your own sort of your own testing, and obviously sometimes people want to happen to do practicing of sort of ultrasound guided procedures, but they're certainly I think like a couple of £100, something like that, which at least for a sort of half decent sort of phantom. We've had a go at making our own, and I think I had a shot at that recipe that you used recently, Stu. I don't think mine was quite as successful as yours. Mine came out looking like a jelly or something. But there are other options. You can build your own phantom. I've got to say my one didn't last very long. It disintegrated after about 2 days. I think they can last longer than that. And there's various other.
You can buy them with obviously a phantom. It usually has sort of specific items within it that are measured and regulate, that you can visualize them in certain ways, etc., etc.
If you're looking at buying something like that, I mean, that really is expensive, isn't it? I mean, we've had sort of bought in pack testing where they brought along a phantom and they've done sort of like various tests and whatever. And obviously it costs that much more than a regular sort of pack test. But I think to actually buy as one of those sort of good quality phantoms where you've got all the sort of like testing, then I think you're talking sort of several £100 at least, aren't you, for something of that nature? Would that be right, Doug?
Yeah, in my experience, a good test, you need two different types of phantom. One of the phantoms that you need is what's known as a resolution phantom. That tests the resolution of the system. But perhaps more important, you can actually see it on the image I've got frozen here. It is contrast resolution. In other words, the ability to pick up a difference in echo texture between structures. So that is really, really important. What's known as contrast resolution is really, really important, and it can get very, very subtle. And a contrast resolution test object is an expensive little beast. It really is, because it's got to be standardized. And what you're paying for is the standardization. It's not something that can be homemade.
Mm-hmm.
And my experience, they cost at least £1,000.
Yeah.
And they need regular servicing.
Mm-hmm. Yeah.
So do you want to talk us through quick little test that people can do in their clinics and things, Doug, or just
I mean, one of the things that people always talk about with Ultrasound Pro, you hear it, oh, I've dropped the probe, better check to see if there's any dropout. In other words, damage to the face of the transducer, where the transducer material itself is a ceramic, and you know, as a ceramic, it can break, it can crack, and when it cracks, you may lose, it'll lose the ability to transmit ultrasound. And there's, I've got a little paper clip here that I've just straightened to create a sort of thin wire. And what I can do is I can run the wire across the face of the probe. Now I'm going to need to turn up the gain on the machine for you to see this, and make sure that it's got some gel on it. But if I just, I don't know if you can see that very well. Let me just put it in the right place. As I run this across, can you see that line of contact move across? Now, if there was a dropout, a broken transducer crystal, what would happen is at a consistent point, that would completely disappear, and then it would come back. Now, I'm being quite gentle here, and I'm running it along a fairly dry surface. I need some more gel really across that surface to make sure that it's damp and provides good contact. There we go, that's better. You can see as I move it, now it would completely disappear at a point if there was any problem. You can see if I just freeze the image and then scroll back. Okay. Can you see right at the top? Just up here, very small indeed, and that's the point of contact. The bit below it, this bit, is actually showing the how in reception you use a wider aperture. And you'll notice that I have completely turned off the compounding to do this. Because if I had the compounding on, then you would see the different lines of sight with the compounding too, and it would be even wider, it would look like that. Oh, it's a little man.
Great, Doug. That was brilliant.
Is that useful? So that's what they're doing. Just with a flat. Some people use you can use any sort of blade edge or anything like that to run across the surface. But you've got to be careful and got to be gentle about it. Make sure that you have some also that it's moist contact in, because obviously if it's dry contact, you're not going to get anything. But it's a useful thing to do. Bear in mind that what that's doing is it's testing the whole system. So you could have, I'm just going to press the freeze button on the probe, you could have a core connection at this end. In all those, you know, a little bit of muck inside there gets in the way of one of the connections, and it'll cause exactly the same effect. So the first thing to do if you think that you've got dropout is reconnect the probe and give the connection a bit of a blowout to try and shift any dust or dirt that might have got into it. Now that's more often a risk if you are constantly reconnecting and disconnecting probes. And if you've got a portable system, you're more likely to be doing that.
And that's why it's so important to look after your probes that aren't in use, isn't it? As you kind of mentioned there, you know, if you're lucky enough to have a hockey stick and a linear probe, like we talked about the different uses of those in the previous webinars, but it's why it's so important to put them back in the box, keep them stored safe. You don't just leave them on the shelf gathering dust.
Absolutely.
It's not just a robust sort of power socket, is it? It's you know, sensitive bits of kit.
That these probe connectors are quite sophisticated in their own right.
Yeah.
And you know, they perform an important task. So do look after them.
Real. So if I take you back off screen sharing, Doug, or can you do that?
I've done that.
Wonderful.
And I'll reconnect my other camera so that you
Okay.
can see my pretty face again. Not
Fab.
want to.
think we might have lost Rob somewhere.
Yeah. So what's different there?
Brilliant. So yeah, so guys, that's just a sort of an overview or discussion really we wanted to have around machines. We talked mainly about probes there, but obviously your system as well is important. The cleanliness of the system, and when you're purchasing systems, do think about the cleanliness of how you maintain your system and everything else, and the nature of what you're going to do with it, and the types of systems that you need in terms of the range of different optimization tools you have. All of these different aspects. Dave, you look like you're poised to sort of come in there with some comment.
No, I was going to say something. I was going to say something detrimental about Rob and the way he looks after his machine, but don't worry.
Oh, right, okay, yeah. That kind of, I guess, sort of brings that sort of more physical checks part of the discussion tonight to a close. Before we go any further, I want to sort of just share a couple of documents in the UK here that I often refer people to when they're thinking about the governance issues or broader issues to consider when integrating ultrasound into their practice. And my go-to around these two things are one document by the Royal College of Radiologists, so the RCR, which are the standards around an ultrasound service provision. As soon as you say that, it tends to get people who don't work in a radiology or traditional imaging setting sort of saying to you, oh yeah, but I don't run a focused ultrasound service. I run a physio clinic. I run a sports and exercise medicine clinic. I don't just focus just on ultrasound. But this document is actually, we were just saying before we came on tonight, the foreword of this document is actually a really good read around the landscape of ultrasound, how it's utilised in so many different domains now, both in the UK. So sorry to those who are overseas, but sort of a primary care and a secondary care, in other words, a community-based environment and a hospital-based environment. So I'm going to share the link on the chat, and I'll put a full link onto the page and stuff as well in due course. But this is the link now that I'll put on for the actual RCR document. Hopefully that works. You can just Google RCR standards for ultrasound practice. Let me just do one other link because I don't think that's worked. And within this, there's probably one of the first things to kind of talk about is probably around reporting. And it's often an area of discussion when you're looking at radiology compared to, say, point of care environments, which is at the moment our topic for discussion next week. For me, it doesn't really make a huge difference. I think in terms of radiology environments, often you're using reporting software, and so it tends to be kind of, it's a core part of what you do. In a point of care environment, from my experience, you should be reporting on your images. Now, it may be that takes a slightly different format in terms of incorporating that into your letter writing or whatever. But if you look at all of the core kind of competencies around and the training programs around ultrasound in the UK, and if you look at, say, case guidance around course content and everything else, there's a significant focus around reporting because it's of medical legal importance, and it's part of your medical legal responsibility and record of your patient care. And so reporting is an interesting topic in its own right because it's quite an art, I think, in terms of the terminology to use, how you describe an image, and how you then link that to actually the ongoing care of the patient and the ongoing management as well. Dave, I'm not sure if you wanted to add anything in around reporting and the nuances of it.
Yeah, I mean, there's. I think Rob's trying to get back in, actually, Stu.
All right.
Is frantic messages coming up. We could leave him out for another 20 minutes. Yeah, I mean, I think the thing is, as we know, there are sort of various guidelines, aren't there, in terms of what a report sort of should include. But there are lots of different styles. Some people sort of report in order of sort of like importance, if you like, in terms of what they've seen. So they'll put the most sort of significant finding first. Other people tend to report in a very sort of like, sort of systematic sort of way. I think obviously the key thing is to, you know, is to say it as you see it. So, you know, obviously trying to be objective. That was certainly the way that I've always been taught, and my understanding of the guidelines, principles is, you know, to be objective, to only report, I think, as well on the area that you've been sort of asked to report on. You know, don't sort of, you know, do sort of like, or certainly make sort of huge generalization statements that you can't support. And I guess it's the key thing is obviously making sure that it actually correlates. It answers the clinical question, it correlates with the images that you're storing, and that there is a sort of sensible, logical format to it, whichever is your sort of preference, really. I think it's just, you know, finding a sort of standard way that works for you, such that you don't omit to say anything of any significance, but equally at the same time, you know, refrain from sort of like sweeping generalizations or saying anything that you cannot objectively back up with your images, I guess, is the way that I would recommend people to go on it. I don't know if you've got anything else to add to that.
I guess one thing is around, just occurred to me, is around the differences between if you're performing the ultrasound and you're reporting it, if then writing that back to somebody who's referred to you, I think it's important to address the question that they ask you. If obviously you're seeing a patient as part of their care pathway, you're assessing them, treating them, ultrasound's part of that, then you'll have the questions maybe in your head of where you're going to do your focus evaluation. But I think if you're receiving a request to do an image investigation in a radiology or an imaging sort of centre, then answer that question is important. The other thing I would just say is around ambiguity of statements. So I think you know, certainly avoiding lots and lots of ultrasound jargon, and there's certainly plenty of that out there that can be utilised. You know, try and break it down into something that makes clinical sense to either the person referring to you or the person who's just going to read your assessment report, so that actually makes sense, rather than just a whole bulk load of measurements and words around something that, you know, hypoechoic, hyperechoic. People won't necessarily understand the implications of that and what it means. Rob?
I think, succinct, nice, and don't say things that are, you know, I certainly from a sort of physio perspective and working with other physios who scan, you know, you tend to see a lot of sort of physio jargon creeping in. So hingements, people talk about frozen shoulder, sort of throwing in almost like oftentimes a diagnosis, but without sort of linking it to any sort of particular evidence, if you like, from what they've seen. Or again, I think it's just get back to what we were saying before about being really objective, but just, you know, with a reporting on an ultrasound sort of hat on, it's saying what you see, and then in the rest of your clinic letter you might talk about the diagnosis that you deduce from that. But I think you've got to just try to be really objective in the actual sort of like scanning report.
I think it should be the format is exactly the same as the format that you use in a acute setting in a radiology clinic, really. But then maybe at the end of it, some recommendations. So, for example, if you do an ultrasound report in an acute setting, it is all descriptive, isn't it? There is no real. There shouldn't really be any, like, you know, like this might be a frozen shoulder, whatever, in the body of your text. At the end of it, you might sort of, in your conclusion, you might say these, you know, findings are, particularly if you're a physio doing it, so you kind of perform a dual role, then you would be able to do that. And that's fine. But I think, and then also sometimes a bit of advice is actually not bad, but that all has to hinge on the factual information. The factual information has to be absolutely like based on what you've seen, and not what you infer or what you think you might have seen or what it might represent. And I think that's what some people, particularly clinicians, I think they're guilty of that probably a lot of the time.
I suppose the other
we do all the time.
just around sort of glossary of terminology. So I guess the real sort of absolute classic is the bursitis, isn't it? I mean, we see it on so many reports, bursitis, but yet, as we know, there's, you know, real sort of lack of definition around what a bursitis actually is, and the significance of, you know, different, if you like, the width or whatever of dimensions of a bursa, and when does that constitute a bursitis. And so I guess as much as anything else, it's knowing your audience, and are you going to be sending them images, or are they just going to be getting a report landing on? We see so many people who go for ultrasound scan evaluation of their shoulder. The report says bursitis, and so everyone then concludes from that the treatment is an injection.
I was about to say, like, it's a really good point, Dave, because the terminology that you use in a report, or your description of ultrasound image, it can lead to a much more interventional focused treatment. The other one is the bursitis. The other one is a synovitis, or a synovial kind of thickening. They can also trigger sometimes people to think about steroid injections, you know, those kind of things. So again, really good point, Dave. You know, think about what the implications of how you're describing something with your terminology.
And I think we cover it on another webinar, but there's that whole thing around sort of normal, you know, normal age-related sort of changes and normal variants and this kind of thing. And I think there's an article, isn't there? The name escapes me. It's my favourite one as well. But it's like 94% of shoulder scans were reported as having like bursitis or acromioclavicular joint osteoarthritis. But the real
Girish one.
But the real elephant in the room with it is the fact that there's no definition around sort of like the actual extent of those changes. So that really what they're saying is 94% of ultrasounds of people over the age of 45 show age-related changes, which suddenly becomes a less dramatic title to that article, doesn't it?
I think you're referring to Girish in 2011, where they stated that 78% show subacromial, subdeltoid bursal thickening. I'll just drop that one onto the Facebook feed for you. Don't worry.
That work of art.
I think it's a really, really good point around, you know, you talk about, you know, we talked about the hard governance of it, that, you know, we should be reporting, we should be documenting. This is part of the medical legal responsibility of using these devices in our practice, but the actual art and the detail and the considerations when you're reporting an image and the implications of that is also a really, really interesting thing. And that then leads us on to, I think, if you think about the core kind of premise of, if you're going to report something, it should be kept along with the image that it refers to, and those two should never be separated out. There's a real issue, I think, at the moment that I don't have an answer to, and there is no absolute on it, around image storage, the sort of topic that keeps me awake at night. You know, when you're working in radiology settings, it's all automated. You know, you're storing images, you're reporting images, you've got PAC systems or whatever. It's all automated. You're labeling the image, and that's another discussion to have in terms of quality of what you're doing with your images and storage and how you do it. But point of care environments is another discussion, and often get, you know, discussions of, should we be storing images, should we not be storing images? I think the ideal is if you can store an image and you have a way of storing an image, then absolutely, to go alongside your report, and you make sure that you store that all appropriately and everything else in line with GDPR and patient sensitive data and everything else. But it's a challenge. I'm fully aware that it's not as easy as that in point of care environments. I'm not sure you guys think about that and thoughts.
Yeah, certainly it's more challenging. I think one of the issues, and I know we've sort of talked about this before, you know, sort of like back in the day with NHS, when we weren't attached to PACs, and, you know, images were being stored on machines, and then, you know, other sort of storage devices, as it were. And then the sort of whole question comes up as if the image isn't inextricably linked with the patient episode, then obviously, you know, then immediately then you've got this opportunity or risk or whatever you want of the images then become, you know, potentially put with the wrong patient episode, or it could be mixed up with the, so as soon as you lose that immediate sort of banking of the image that you have in radiology, then the whole sort of issue becomes a lot more complex and a lot more tricky. I mean, we have in private practice, we have a diary system which is GDPR compliant for saving images and videos, and so we can upload onto there, but it still doesn't get you away from the fact that you could put the wrong images, or you could store the images against the wrong client's information or whatever, so you lose that robust sort of, if you like, journey of matching sort of image to client. So
but how would that happen then, Dave? Because if you kind of annotate and you put patient details in, when you scan and then you export it, then the name and the details are on the image, aren't they?
Yeah, but you've still got the thing of like human error or whatever, because there's nothing to stop you annotating the wrong person's details on it. There's nothing to automatically make you move on to the next sort of episode on your machine or whatever. So it's because it's not automated, it doesn't sort of flow through. So we have to, take the images off the machine and then load them up onto the correct episode of the on our diary system. So there's lots of process and sort of opportunities.
It's a real challenge, I think, when you're outside of that radiology setting as to how you manage that, and that's certainly something that people need to consider when starting to utilise ultrasound in clinical practice. How are you going to be doing that? How are you going to be trying to achieve those kinds of things in terms of image storage? And I think probably that if you're thinking as well about doing interventional procedures and things, then having the position of your needle with joint injections and things is also a really good thing to aim for in terms of your governance around these aspects. But I think it's something that has to be mentioned, but it's a real challenge. Steve's just said here, he uses a reference number from the patient management system and the image's date is stamped. So he sort of brings those two together, I think. But I think the key thing is that people actually consider it. That's part of the reason for us having this sort of session tonight on an arguably a slightly drier topic, is so that we flag up things in people's minds and think, okay, I need to think about that. How could I do that? And there's certainly a number of cloud options as well now that are out there. And a lot of the systems, Doug, maybe you want to come in here about system connectivity to PACS and to wireless connections. It's becoming much more common, isn't it? Or not?
You've got to be quite careful. It varies across the world as well. You've got various different considerations that come into this. I'm going to ask what sounds like to me, quite a simple question. How long should you keep an image for?
Well, if you're talking about like physiotherapy notes for an adult, have to be kept for 8 years. That's the recommendation. So I don't know if radiology is any different. If it's for a minor, I think it has to be, is it 21 years for someone, for a minor, and for an adult it has to be kept for 8 years.
Great question, Doug.
But that's
the reason we invited you along.
Yeah.
There's another question that leads out of that, which is your notes. We've talked about ultrasound being used in many of these environments as an adjunct to your practice. So, if it's being used as a tool in your examination of the patient, do you actually need to keep an image record? You've used the tool. Do you need to keep an image record?
Yeah, I think if you look, there's various sort of arguments around it, aren't there, in terms of how it's been used? But I think if you look at this from the core concept that you're using ultrasound imaging, you're performing a diagnostic ultrasound scan, if you like, or a scan, if you like, in your clinic, then I think you should be reporting on that or dealing with that as an ultrasound scan or image. I think we should be setting our standards high. In terms of a point of care role here, I think we should be setting our standards high as we can, in terms of trying to meet the standards that are expected from radiology colleagues. I don't think we should be sort of saying, okay, I can do an ultrasound and I'm not going to sort of mention it, I'm just going to do it as a tool, as part of what I'm doing. I just think the device needs the respect. I think it requires the respect of, if you're doing something, do it well, do it properly, and comment on it. Even if that means, I evaluated a region with ultrasound today in clinic, and it was normal. It can be as simple as that, as part of the clinical letter, as part of the assessment, as you would do for a physical examination test or whatever. But I just think,
Yeah.
I think one of the things that we talk about on the course, and I think this is probably sort of relevant here as well, isn't it? And that's that sort of, the duty of care side of things. And as a clinician, anything that you do within your sort of practice has to be done to the standard that so you can't just say, well, but really I'm a physiotherapist, I just use ultrasound as a bit of a sort of like, bit of a added sort of ploy to what I do or whatever. That if you are stating that the ultrasonography is part of your clinical practice, it has to be performed to the same level and the same standard as everything else that you do. That's the lines. So I'm talking here particularly I guess the relevant benchmark here is advanced practice physiotherapy, for example. So everything that you do, which is an extension of your practice, has to be done to the same standard. You have the same duty of care as your sort of, if you like, your core areas of practice. So you can't say, oh, sorry, I'm not very good at that bit of it, or something like that. You have to be able to deliver the same standard of care. And I think, that probably comes into it. If you are going to use an ultrasound on a patient, notwithstanding if you said, oh, I'm just training at the moment, so, this isn't a sort of formal scan, but if you are suggesting that you are performing an ultrasound as part of somebody's assessment, then I believe, my understanding of the rules and regulations are such that, you have exactly the same duty of care and exactly the same duty binding you to the standards around that aspect of your assessment and treatment. And therefore, 100%, you need to, talk about the results of your scan. But purely, I guess, from a documentation perspective, because if you saw a patient a year ago and you don't write down the fact that you do a scan, and then the patient says, well, you did a scan of me, and you're like, did I? I don't remember that. That, to me, would be a fairly ridiculous situation to find yourself in. So you need to be documenting everything that you do. And obviously you should be consenting them for performing a scan. And advising them about the risks around the scan. So I don't see that there's any way that you can not mention it and not put a report in there.
And then a couple of really interesting and very, very relevant point, which kind of skips me. I just realised the time as well. Where's this hour of clinical governance gone? It's been
just goes, doesn't it?
It's the quickest session for me. I love all these things. But it's a really, really important point by Angela, that having the images allows you to do the audit process as well, which is a key pillar of governance. Your ability to audit back your images, marry those up in terms of, okay, was I right with that call? Did it lead to the right investigation? Did it lead to the right treatment? Really good point, Angela. Thank you for giving me a nudge on that. Very grateful.
And you wouldn't get asked in private practice, well, in all practice, but they'll say, oh, can you send me those images, or can you send me the report, or would you mind sending those images to this other, you know, so, and certainly, yeah, so I think you know, I think it's good practice that you know, certainly store images where there's anything relevant to discuss, or if it has any impact on that patient's treatment or management, then I'd say that you would really have to be storing something there, or certainly writing a very detailed report that you know, that could be referred back to.
Yeah, absolutely. I think that probably covers sort of the debate around image storage, which is never an easy one. I don't think, particularly for point of care people, to sort of get a you know, make an easy thing just to transition overnight. It takes some consideration, but hopefully we've planted a flag in the ground there to sort of make you think about that tomorrow morning when you wake up and have your Weetabix.
Stu, can I just say, I just looked in that document, the RCR document, which is to the ultrasound requirements, and it basically says for image storage that the RCR says that it should be stored for an appropriate amount of time, and it has a reference in there. So I imagine it means that it is different for different areas, and in, you know, particular body parts, whatever, different types of scans, etc.
Yeah. Probably just worth, obviously there's loads of other issues we can talk around governance and things, but I think one other thing is around infection control is really important, and it's something that, again, we often find on courses and teaching programs that leaves sort of people sort of relatively speechless in terms of how should I clean my machine, how do I approach this. I think we get so focused around you know, utilizing the ultrasound, get an image, how do I move the probe, everything else like this. But infection control is an absolutely vital element of keeping your machine clean and keeping your patients safe, particularly if you're going to go on doing anything more invasive. So one of the key things I've always sort of said about this, and I'll sort of launch my sort of views first, is around people assuming that they can use any cleaner on an ultrasound probe. You know, people sort of think, okay, yeah, well, alcohol, yeah. I won't carry that sort of conversation on Rob any further in current climates. But the obvious one is people think about alcohol. Yeah, alcohol. Chuck some alcohol on most medical devices, and it cleans things down and everything else. And I always say to people, and we've created a protocol where I work now that's certainly been pretty rigorously put together in terms of the infection control team's engagement with it. But you know, if you work in a large NHS trust, is engage your infection control team very early on and speak to them about what their expectations are, but also understand what you can use on your machine. Otherwise, it can damage it. Is that right, Doug?
Yeah, the wrong materials can certainly damage it.
Yeah.
You've got to bear in mind that you know, the ideal agent to use is something that is pretty harmful, and it's often quite reactive. So it can affect some of these materials affect metals, some of them affect plastics, some of them will dissolve things. Alcohol is a very, very good solvent. So if you, it will leach out from plastics, particularly bendy plastics. It will leach out materials from that. So you've got to be really quite careful. And now, the materials used by manufacturers will vary. And manufacturers, behind the scenes, there's quite a lot of work that goes on to try and find out what cleaning materials are being used across the world, because they vary a lot, and you know, which are recommended. You know,
in terms of brands and everything else, I guess. I mean, we've got people here from
brands, but also the chemicals too. You know, in some countries, formaldehyde is used for high-level disinfection of equipment.
Guys, if you're outside the UK, guys, just share with us your cleaning products. Let's go for it.
Hey, but Doug, there's
formaldehyde is very common outside the UK.
Formaldehyde.
Really?
Formaldehyde. Most manufacturers recommend its use because it's pretty safe for equipment. Doesn't harm it.
But Doug, don't you think that there's a massive sort of tension between infection control and medical physics departments? Because if you ask the medical physics department what should you use, sometimes they just say, soapy water or something like that. And then if you go infection control, it's like, well, they want some sort of fairly robust sort of infection control measures that are not necessarily, like, the manufacturers are not necessarily thinking that all of them are safe for their probes.
Think about the drivers for the people you're talking to. You know, what the driving motivations are for the people who you're talking to there. In medical physics, they're thinking primarily about the care of the equipment, and they're thinking about risk in terms of damage to the equipment. Infection control, the drivers there are all about cross-infection risk. So they are going to want to minimize as far as possible that cross-infection risk, and they'll want, if they believe there's any risk of cross-infection, they're going to want to have something, you know, the item ideally put through an autoclave, which you can't do to an ultrasound machine.
Yeah.
You know, there are your compromises. Now, actually, cleaning, disinfection, we call it CDS because it's cleaning, disinfection, and sterilization. If you go down to a central, to a central sterilization department, every dirty instrument is put through a process that includes cleaning, disinfection, and sterilization. You follow a 3-step process. Now, with ultrasound equipment, it's pretty difficult to sterilize it.
I guess it's worth also saying at this point we're talking MSK here, so we're talking surface linear probes predominantly here as well. We're not talking more basic probes. Considerations
there about what is the risk of cross-infection? Well, if you're going to apply the probe to broken skin, then think about it.
Yeah, and I think the other thing is you may require different cleaning for the system in comparison to the probe face as well. There's considerations around that as well. And again, it's just about us sort of trying to sort of say to people, who are looking at getting into this, maybe in standalone clinics or whatever, consider these aspects and get these things in place.
Yeah. I mean, it's been very interesting with the recent lockdown, COVID-19, etc. The use of ultrasound in risk areas. Big, complex ultrasound scanners are not the easiest things to wipe down. They're not really intended for that. Point-of-care designed machines, scanners that are designed to be used in a point-of-care environment, are often designed to be much more easily wiped down and decontaminated after use, because they're designed for use in an environment where body fluids, etc., are likely to be flying around.
That makes sense.
And so you can look on that, and something like the little machine that I showed earlier, that's designed for a point-of-care use environment, and actually that's quite important if you're thinking about injections and that sort of thing as well. It's quite important there. You want to have a machine that's simple, that's easy to wipe down.
Yeah,
and probably has more buttons on it.
We've had a question saying, could we recommend products for the probes and things? I'm just going to say to guys, contact your system manufacturer and engage with them about what they recommend in terms of cleaning products. It's actually impossible to recommend.
Just the manufacturer, also engaging. Yeah.
Sorry, so Doug, I missed that bit.
It's also engaging with, as you said, with what the country, the recommendations are within the country, what the infection control people, what the supervisory bodies say. In this country, in the UK, the move is towards wiping down probes with, ideally you want to use something that decontaminates it and disinfects it, and then you've got the Tristel Duo, which is a chlorine dioxide based material. It's a bit more expensive than Clinell wipes, but it actually does the job. It's designed to disinfect probes.
Yeah.
That's what we use, isn't it?
But it is very expensive. But we use it again because we are doing lots of injections and so forth. But it's sort of £100 a bottle of foam, which doesn't,
not as expensive as your latest Audit toilet, though, Dave, is it?
I dab a little bit behind my ears after every clinic. So. That's more expensive than the aftershave I use.
Nice and clean.
Crystal Duo.
But higher level disinfection, the recommendations are that you use a disinfectant or another process entirely, either ultraviolet light based or a plasma based. And those mean that you have to go and put the probe in a machine for a period of time. And those machines cost many thousands of pounds.
Yeah. So I guess the key messages are: think about how you clean these machines, engage, as Doug said, relevant professional bodies, the country that you're working in, your manufacturer of your system, and explore it. But certainly something to consider. I'm just conscious of time, so we're probably about to sort of draw it to a close, I think. I think one other thing I just wanted to mention was around policies and management of things. Again, I think I'm probably thinking here more around a point of care environment probably, but thinking about how you're going to handle findings from your ultrasound investigation. Certainly unexpected things can come up with any of these kind of imaging investigations, and having written policies and established pathways or plans of action of how you're going to communicate either with a GP or whoever, or having a pathway to a radiologist and their expertise for further imaging or other imaging modalities is really important. So I think I just wanted to sort of just mention that as well in the session tonight, about just thinking broadly about other scenarios that can occur and how you would anticipate those and how you would handle those situations, and also checking them on a regular basis. Don't just write something up and then park it. Check it every 6 months, make sure that's still going to actually work if that situation was to occur. I don't know if you guys want to add anything more to that.
I think in private practice, it is probably one of the most sort of important things, really, that it can be so sort of complex, particularly working in central London. So many of the people that we see, come from, outside of London, so they don't have a GP locally, and some of them are coming through insurance. So, in some ways, those might be easier to manage because then via their insurance, then you can get them reviewed with a consultant quite promptly. But if they're self-funding and they come and see you, there's not always a sort of natural, obvious, easy pathway back into services, particularly if you really feel that they need to be seen quite promptly. So, yeah, I know there's not a one-size-fits-all oftentimes pathway for these people. So you have to really sort of, have dialogue with the person, discuss your sort of concerns, and and sometimes it's just a process of working out with that particular person what is going to be the most efficient way to get them seen and reviewed, whether it be getting them back into their GP or getting them reviewed urgently in secondary care. So it can be a real issue at times, particularly if it's sort of, dare I say, sometimes if it's just sort of low index of suspicion, but there's just something on the scan that you're not quite happy about and you just want to get them reviewed, then those can actually be some of the more tricky cases, if you like, because then you're then having to put them sometimes for a lot of, I say inconvenience sounds like the wrong word, but you might be sending them off to go and see somebody and then go and get reviewed somewhere else, and it all comes down to the fact that you can't, in the setting that I work in, just send them round next door to go and get an MRI scan, for example.
Yeah.
So it's on a case by case basis, yeah, they can be some of the more tricky scenarios, I must say, when you're working in that setting.
Yeah, so certainly some sort of anticipation or some thought into those situations of what those scenarios could be like before they actually occur is definitely recommended from us. I think we'll probably draw it to a close there, unless you guys have anything else particularly to add in. Hopefully that's been a useful session, guys. It's been, I guess, really just an overview of some of the smaller aspects of some of the governance considerations really around MSK ultrasound and using it in your practice. Many thanks to Doug again for joining us. Conscious that you've been sort of watching from the sidelines very patiently for the last 25 minutes. So thank you very much for joining us again and sharing your expertise with us. We may well be calling on you in future weeks as well. And next week we're focusing on, I think probably it's more around, we get a few questions basically around, working in this kind of environment. What's it like to work in a radiology setting and perform these investigations? What's it like to what the challenges you might face in those different types of environments, point of care against radiology. And we've got a lot of expertise and experience around this kind of topic and the challenges that you might face in those kinds of environments. So we wanted to do a chat around that. And it's just really our experiences, essentially, a bit of a narrative around that next week. So that's going to be next week's topic. Send in your questions and things in advance, by all means. Very, very keen to get questions and interaction. It really gives us the opportunity to put a bit more flavour around some of these discussions as well. This week will be back up on YouTube when I get myself sorted out and get it on there. It'll also be on Spotify and iTunes and things if you want to listen to it on your more than one walk a day now in the UK, or in England, sorry. Yeah, feel free to watch it back, send us any feedback you've got, and we look forward to seeing you all next week. Thanks very much for your support again.
Cheers, thank you.
Cheers.
Yes.
Thanks, guys.
Thanks.
Bye.
Bye.
Bye-bye.